Today we are demonstrating the infero-superior axial projection, otherwise known as the Lawrence method, used to visualize the shoulder joint. The purpose of this projection is that it is an alternative to the superior-inferior axial projection, specifically used for trauma patients who have limited mobility of their shoulder or cannot move from a supine position to accommodate the patient positioning for the superior-inferior axial. Equipment needed for this exam: a 10 by 12 IR, a vertical IR holder or sandbag, a lap shield, a large sponge, and markers. Position of patient. With the patient in the supine position, elevate the head, shoulders, and elbow approximately 3 inches on a radiolucent sponge in order to center the glenohumeral joint to the center of the IR. Position of part. As much as possible, abduct the arm of the affected side at right angles to the long axis of the body. A minimum of 20 degrees is required to prevent superimposition of the arm on the shoulder. Keep the humerus in external rotation and adjust the forearm and hand in a comfortable position, grasping a vertical support or extended on sandbags or a firm pillow. Support may be necessary under the forearm and hand. Provide the patient with an extension board for the arm if necessary. To be sure of your patient positioning, that the arm is in external rotation, palpate the humeral epicondyles of the affected side to assure that they are parallel with the table. Have the patient turn their head away from the side being examined so that the IR can be placed against the neck. Using a 10 by 12 IR, place the IR on the edge against the shoulder and as close as possible to the neck. A grid is not needed for this projection because the body part is not more than 10 centimeters. To be sure of proper positioning of the IR, palpate for the glenohumeral joint space to help center the joint to the center of the IR. Support the IR in position with sandbags if needed, or use a vertical IR holder. With the SID at 40 inches, place the central ray horizontally through the axilla to the region of the AC articulation. The degree of medial angulation of the CR depends on the degree of the abduction of the arm. The degree of medial angulation is often between 15 and 30 degrees. The greater the abduction, the greater the angle. Collimation. Adjust the radiation field to 12 inches in width on the collimator and to 1 inch above the anterior shadow of the shoulder. Place the side marker in the collimated exposure field outside of the anatomy.
So today I'll be giving an overview for positioning for the infero-superior axial projection to demonstrate the shoulder joint. Most specifically, I'll be demonstrating the Lawrence method. For this particular projection, you're going to be needing calipers to measure thickness of the part. For this patient, today we won't be using the grid because the body part thickness is not more than 10 centimeters. However, this can vary with any patient that you meet in your actual site. Moving on, some other key materials that you need or equipment is going to be a lap shield, marker, appropriate size sponges to help elevate the body parts. a 10 by 12 image receptor, and a sandbag to help hold up the IR. So moving on from this position, in terms of actual patient positioning, we want to make sure that the shoulder, elbow, and head is all elevated at least 3 inches above the table. By doing this, we're using appropriate size sponges. As you can see, we have 2 stacked up on top of here, on top of the shoulder and the elbow, as well as 1 right underneath his head. Moving on to actual patient positioning, we want to go ahead and make sure that the humerus is in proper rotation. In order to do that, I'm going to be feeling for the humeral epicondyle and helping the patient rotate the humerus in an external rotation. Moving on, I also want to make sure that our 10 by 12 image receptor is as close to the neck as possible, with the patient's head facing away from the image receptor. Marker placement is obviously key here, and key palpation points for this specific projection, not only the humeral epicondyles, but you also want to go ahead and palpate for the glenohumeral joint to make sure that it is in line with your IR, as well as in line with your CR. And
For this exam, we're going to have the SID at 40 inches. The tube is going to be placed horizontally, with the CR also horizontal, directed at the area of the AC articulation, exiting at the scapulohumeral joint, centered on the IR. Because we're using a 10 by 12 IR, we're going to collimate accordingly to the body habitus, leaving 1 inch on the interior shadow of the shoulder. The degree of medial angulation of the tube depends on the abduction of the arm. The more abduction, the more the angle. The range is going to be within 15 to 30 degrees. For this, we have it around 15 degrees.
the image evaluation criteria and anatomy demonstrated includes the following: evidence of proper collimation and presence of a side marker placed clear of the anatomy of interest, scapular humeral joint with slight overlap, coracoid process pointing anteriorly, the lesser tubercle in profile and directed anteriorly, AC joint, acromion, and acromial end of clavicle projected through the humeral head, bony trabecular detail and surrounding soft tissues. The anatomy or structures that are shown include the following: an infero-superior axial image of the proximal humerus, scapulohumeral joint, lateral portion of the coracoid process, as well as the AC articulation. The insertion site of the subscapular tendon on the lesser tubercle of the humerus, and the point of insertion of the teres minor tendon on the greater tubercle of the humerus are also shown. Typical conditions or clinical findings that may call for this specific X-ray request include assessing suspected dislocations and proximal humerus pathology. Because it is so effective in demonstrating the articular surfaces of the humeral head and glenoid cavity, it is also used for suspected cases of Hill-Sachs defect, which is a compression fracture of the articular surface of the humeral head. Positioning tips from an actual radiologic technologist. Since you are using this projection because the patient is unable to move due to injury or some type of traumatic event, it is important to move slowly and communicate your movements in order to get the patient to feel comfortable and cooperate, and also to minimize unnecessary pain. Due to the short SID and the supine positioning of the patient, the tech should be mindful of the X-ray tube and the potential of bumping into the patient's lower extremities and the gurney or table. Always shield the patient. Breasts on women can be easily shielded without obscuring anatomy on this specific projection, and reproductive organs on both men and women should always be shielded.